The MI is very interesting technology. When I first saw it, I was skeptical that it would actually work, and I was using a previous device that was like a regular arthroscopy setup, and it worked pretty good, but it was cumbersome. And it's very difficult to have cords in the office and reusable stuff, because then if someone breaks something, or someone doesn't put it away, it becomes very, very expensive. Now, the MI is great because it's totally disposable. So you don't have all these cords. You can do it very quickly and easily, and then when you're done, you can throw it away. If someone happened to drop it and break it prior to using it, it's a relatively inexpensive device. Now, the big question mark was, am I going to get a good picture? Is it going to show me a good enough picture that's going to make it worth it? And it does. It's a very, very nice picture. It allows me to get pictures and videos, and when a patient comes in my office, and I can do the procedure on them and then give them pictures and videos after, it's great. Then they have their record and they leave with it. My patients like when I can tell them definitively what is wrong with them. What the MI does is allow you, just like an arthroscopy, to be 100% of what the pathology is, because you're looking at it. Now, an MRI, as we know, is a computer blended picture of something, and it can be skewed if you've had either a low quality MRI or if you had previous surgery. And what patients want, and the reason that my most dissatisfied patients that come to me as a second and third opinion doc are that the doctor told them they were going to do great and they didn't. Doctor told them they were going to have a meniscal tear and they take care of it, and it didn't work, and they're mad at the doctor. And in reality, the doctor didn't do anything wrong. He just, in the office, did not see that the patient had a meniscal tear and a condyle defect that was significant. And now I can look at that and I can tell him going into surgery, hey, you got a meniscal tear, we can take care of it, but you also have a condyle defect, and I can take care of that, but your pain may not all go away. So you're setting a proper expectation, and that leads to a more satisfied patient and makes my life easier. The adoption process was slow in that I first had to figure out how to use it. And once you figure out the difference between a 30-degree scope, which we're all used to using, and a 0-degree scope, and once you have an algorithm that works, and I think we've developed a very nice one for people to look at, then I think you want to sit there and do a patient who's easy. You want to do someone who has a virgin knee, or someone who's had a previous ACL where they've taken the fat pad out. You want to do someone that's not obese and someone that's totally calm with needles. And pick the easy patients at first and give yourself some time and relax, and you'll figure it out. As you get better and better with it, you'll use it like I do, where you go in and it's literally a 5 to 10 minute procedure. You see what you want, you get the pictures, patient's happy, I'm happy. But I think it has to be a gradual, step-by-step process. You have to be patient, and it's going to be a very good tool for you to incorporate in your practice. The technique development has been an ongoing process. When we first started this, I had people sitting up, and that allowed some traction on their knee because of gravity. It seemed like the right thing to do. The problem is you don't scope people sitting up, you don't scope people with their knee at 90 degrees, and they don't relax totally. Now we just lay them down. I have them laying down flat, put a pillow under their head, and it gives them the option to watch what I'm doing, watch the video monitor, or look at their cell phone or sleep. And then I want to make sure they're very relaxed. I have their knee straight. If it's their right knee, I keep them near the right edge of the table. And I mark the inferior pole of the patella. And then I want to find the soft spot on both sides of the patella, which tends to be about a centimeter distal and 1 to 2 centimeters lateral or medial. And I mark that. Then after I've marked them, I'll bend their knee up, I'll feel it, I'll make sure that that's the soft spot, make their leg straight again. Then I'll take a lidocaine with epi procedure, a lidocaine with epi mixture, and I will inject them. I put about 3 to 4 cc's in each of the portals, and when I hit the portal, I'll go deep and maybe put a cc in the fat pad and the capsule. The pain is usually in the capsule itself. You don't want to put a lot in the interarticular portion or the fat pad, because then it'll swell and extra fluid makes it hard to see. Then I'll usually go to another room, let the patient relax. I'll come back in about somewhere between 5 and 10 minutes. And I'll talk to the patient, say, how you feeling? And they're saying, hey, I'm doing fine. And I'll look, and you'll see the blanching from the epinephrine. Then I know they're ready to go. Then I'll re-prep the portal sites, have my assistant, we'll both be sterilely gloved. She'll hand me my device, and she'll sit right next to the patient so he can or she can take a look at the screen while I'm doing it, and obviously I can see the screen. Then we enter the knee. I usually go from the lateral portal because that's where I'm used to scoping from. I go directly down towards the medial joint line, and then I find the medial joint line. I usually will see the meniscus. Do the medial portion of the knee. If I have to put a valgus thrust on the knee or I have to bend it, I can do that very easily by just hanging the leg a little bit off the table and pinching it. Then I'll go back, take a look at the ACL, and then go to the lateral side. The lateral side is usually the difficult one to see, but in this technique it's very easy because you drop the foot about 15 degrees off the table and then just pinch it with your hip against the side of the table, and that'll open up the lateral aspect of the knee, and you'll be able to see things nicely. After I've done that, then I'll check full motion. I'll bend the knee down to 90 to make sure there's no cartilage defect, and then I'll go to the medial side and do the same thing. Because you're seeing the meniscus between 0 and 30 degrees. Between 30 and 90, you're checking the articular cartilage. Then we aspirate as much fluid back out of the knee, because sometimes you'll have to add a little fluid to if you get blood or you get problems with debris. Aspirate as much as you can, pull it out, put a Band-Aid on, and you're done. The perfect patient for the MyEye is in several groups. My favorite patient is the guy who's had a previous meniscal tear and now has pain, and he's getting catching and locking, and they usually walk in my office with an MRI, and I look at the MRI, and an MRI read is re-tear of the meniscus. Well, you usually don't see that very often, but this guy now has an MRI that says that. You look at the MRI and you see an abnormal meniscus, but any meniscus is going to look abnormal after you've done a meniscectomy. And now I don't know what to do with this patient. Do I tell him he's got to live this way? I don't know who did his previous meniscectomy, or could he have had a bad surgery, or could he have retorn it, or does he have a condyle defect? He's the guy I can look, and I can definitively tell him whether a scope would help him and what his pathology is. The second group of person is the person for some reason who can't have an MRI. Either it's really expensive, secondary to their insurance, they're scared, they're claustrophobic, they live a long way from a scanner, they, for whatever reason, they have a pacemaker. There's a lot of patients that just either don't like it or don't have the option to get it, and they're a good person to perform the procedure on. The indications for doing this are really very similar indications to doing an MRI, but the caveat is it can't be global. For me, it can't be a global problem. If I'm looking for a condyle defect, medial meniscal tear, subacute ACL tear, if there's one or two areas that I really have to focus on, then I'll do it. If someone comes in with generalized pain, inside, outside, under the patella, then I don't usually do this procedure on them. If they're older, if they're 60 and over, and I'm worried about some sort of spontaneous osteonecrosis or some procedure in the bone, or something going on in the bone itself, then obviously an MRI makes more sense. I think if you're going to undertake this device and the procedure, you need to be patient with yourself, and remember that the patient's going to be calm as long as you're calm. And on some of these, you're going to get there and they have a big fat pad or there's debris, and you're not going to see things really well. And you just have to relax, make little tiny movements. Think back when you did your first arthroscopy. You get to the point you can't see much, and you start moving around fast. You can't see anything. You just got to relax, find a point, either the ACL, the notch, the medial compartment or lateral compartment that move in slowly back, and then flex the knee, extend the knee a little bit, little micro movements, and you're going to find where you're at. You just cannot panic, because what seems like 20 minutes to you when you can't find anything is really 30 seconds, and you just have to relax and you'll get the technique down. I think the people and the procedures you want to avoid, if someone is a histrionic personality, I don't think you do this on them. You got to kind of read your patient a little bit. If they're morbidly obese, probably not a great person to do it on if they have fat around the knee. If you can't palpate the landmarks well, probably not a great person to do it on. as of the technique itself, I think the most important thing is to enter the knee in the soft spot. You don't want to go through the patella tendon, and you don't want to hit the patella or the condyle. Any device you put in the knee could damage the condyle. So when you're going in, you got to go in gingerly, and when you feel something hard, back off a little bit, little tiny soft movements to avoid damaging the articular cartilage. So when we're injecting pre-procedure, we like to do an epinephrine lidocaine mixture. It's usually either 0.5% or 1%. I don't think it matters. It's whatever you have. They both work, or the same. They're both efficacious and work fine. I will inject the skin with and make a wheel of the portal site I'm going to use, and that usually is 2 cc's, and that's the one that's going to hurt. Okay, so I just barely make a little prick. I inject that slowly, and once I do that, then they will actually feel better, because remember, that lidocaine will work its way down. Then I'll go slowly, maybe another 0.5 to 1 cc between there and the capsule, and then maybe a 0.5 cc in the capsule, and then I pop through, and I put less than the cc in the fat pad. And I'm not even sure if you need to have any in the joint. I tend to do just a little. You definitely don't want to do a lot. That whole volume is somewhere between 3 and 5 cc's. I'm not using very much. When I'm doing the procedure, I'll tend to use a saline solution to remove debris and allow me to see. And my only advice there is don't inject very much. It's 1/4 cc little pumps, because if you start getting too much fluid in the joint, then it's very difficult to see. And every once in a while, if I go in and put 5 cc's in, then when I move to my next portion, I suck all that out as much as I can, and then I'll get another syringe, put it on, and start over again. I think post-procedure is interesting. This has evolved too. I think using a little dot bandage is probably the wrong thing to do, because if they have some fluid in their knee, it may leak out. So I use a regular Band-Aid. They're free to walk home, but I make them stand up first, walk around the office, check out, make sure they don't vasovagal on you, okay, because it is a procedure. And I think it's good, sit them up, explain what happened to them, stand them up, talk to them, make sure they're all right. And then I really don't do anything differently. If they have pain that night, I'll tell them Tylenol will usually work well. Do I limit them from swimming, biking, showering? I won't limit them from anything. I mean, this is just like, it's the bore of the needle is just slightly bigger than what we do a general knee injection with. It's actually the same size as what we aspirate with, and really, it's not going to be an issue. When I first started this, I was very worried about infection, because you're doing something that's relatively you're violating, you're inside the joint. But I treat this exactly the same as I would a joint aspiration or an injection, because there's really not much difference. I use chlorhexidine, I think, that on the sites, and when I'm popping in with the device, I go through that chlorhexidine area. I don't touch the actual scope part of the needle at all. I have my one sterile hand on the scope itself, and I'm not touching any of the stuff that's going, actually the needle itself that goes in the patient. I think as you're moving the knee with your other hand, you just have to be careful. And I think if you decide to use a second portal, you have to be very careful that you're keeping sterile technique. Using this device in your clinical setting, depending what your volume of patients and how you set it up, it needs to be done smartly. There's several issues when we look at it. Is number one, how long is it going to take? If you're beginning this, put them at the end of the day. Then you have no pressure on you, everything's done. If it takes you a half hour to do it, it takes you a half hour to do it, everyone will be happy. The patient does not know any difference. As you get better and better of it, you're going to be able to do this in a defined time period, and then you can schedule this like regular appointments. I like to do mine to save them for the end of the day and have 4 or 5 in a room, in different rooms, and I'll go right down the line, hit one, hit one, hit one, hit one, and I'm done. And that's kind of how I like to do it. I have other friends who can get pre-search done easily, and this in some ways has a higher patient satisfaction, is to go in there and say, hey, I know this patient, I know their insurance, I can do it right away, and they will, just like you're going to give someone a shot, they say, listen, hang out here, I'm going to numb you up, I'll be back after I see the next patient, we'll just do it right now. And that works if you're good at it, and you can reliably get in and out in 10 minutes. It's not going to work in the beginning. So in the beginning, your first year doing these, relax, to at the end of the day, figure out your technique, figure out if you enjoy doing it, and it's good for you. One of the nice things that the MyEye does that really nothing short of a diagnostic arthroscopy could help you with is the decision on whether someone's a candidate for a unicompartmental knee replacement or a total. And this is great because I can go right in the knee. We know they have medial compartment arthritis. I can show them. I can look at their lateral, and I can see their cartilage. I can get a picture and a video of it, and I can send that to my total joint surgeons. They love it. It tells them right then what they should counsel the patient on. An MRI, if it may do that, but it's not. You could get in there and say, a lot of my guys will always say on the consent, we're going to consent you for a uni, but when I get in there, I'm looking lateral, and we may have to do a total. And that happens, and that's another disconcerting conversation to have with the guy when he wakes up. I'm sorry, you really weren't a candidate. And I think it's a great indication for that patient.